very common to GI problem in our day-to-day practice. Today, we have two speakers who discuss about H. pylori and GERD. We'll do Q&A session after two speaker presentation. The first speaker is Dr. Vincent Lee. He is a senior consultant gastroenterologist and hepatologist, Gastro, Liver and Surgical Center, Gleneagles Medical Center, Singapore. He was trained in therapeutic endoscopy and ERCP. He got a PhD in liver immunology from University of Birmingham. Dr. Vincent Lee will discuss about strategy to increase success in H. pylori eradication. May I invite Dr. Lee to start your presentation? Thank you.
Okay. Hello all, Mingalaba.
Mingalaba.
I'm just going to share my screen. Let's see if this works. Okay, here we go. Well, first and foremost, I'd like to thank the organizers for this talk and thank you for your time on a Sunday. So I've been tasked to talk about successful strategies to increase H. pylori eradication. Now, this bacteria was discovered back in 1982 by Barry Marshall and Robin Warren. They actually won the Nobel Prize in Physiology or Medicine in 2005. This discovery of the bacteria has basically caused a paradigm shift. For years, we thought peptic ulceration was due to lifestyle factors and stress. But back in 1985, I suppose you can do it then, but can't now, that Barry Marshall actually proven himself not to be infected with Helicobacter. And then subsequently, he took a dose of the H. pylori and basically demonstrated the causative effect of a H. pylori infection and acute gastritis. That's how the link was made. Now, since then, there has been almost 45,000 publications to date. And every year, there's more than 1,500 publications still ongoing on just the topic of Helicobacter. Now, the prevalence varies geographically. The main risk factors, it increases with age in levels of lower education and in developing countries. Now, why do we care? Well, since the discovery, we found that most peptic ulcerations are associated with Helicobacter. So 95% of patients with duodenal ulcers carry the bacteria, whilst 80% of gastric ulcers are infected with the H. pylori. The lifetime risk of peptic ulceration in patients with HP is about 3%. It causes chronic gastritis and is a known primary risk factor for gastric cancer. It is categorized as a group 1 carcinogen. The risk of gastric cancer increases with the duration of infection, particularly it's over 10 years. It also increases the risk of GI maltoma, lymphoma. So under these circumstances, what are the indications to test for and when do we treat this H. pylori infection? Well, since all patients with positive tests of active infection should be offered treatment, the critical issue is which patient should we test for the infection rather than test everybody. Certainly, patients who have had active or past history of peptic ulceration should be tested. Patients with known gastric lymphomas or previous history of early gastric cancer. Any patients with dyspepsia, patients who are starting on long-term aspirin or non-steroidal, so that we can reduce the risk of GI bleed from ulceration. And in some patients with unexplained iron deficiency anemia or idiopathic thrombocytopenia. Now, I was working in the UK and this was a very popular method of treating H. pylori in patients who has dyspepsia and not to overload the services of the endoscopy center. So patients who are less than 60 years of age without any alarm features such as bleeding, anemia, unexplained weight loss, we would do a serology test, and if it's positive, we would then offer H. pylori treatment. Now, certainly that's not my practice. I'm a little bit more aggressive in the sense that I think the risk of gastric cancer in this part of the world is slightly different from the Western Hemisphere, in that our risks are generally a little bit higher, particularly in the Japanese, Korean, and Chinese population. So in my patient, anyone with above the age of 40 with persistent symptoms, I would certainly offer a scope as an endoscopic assessment. Now, as I alluded to, the prevalence of H. pylori in Asia varies. So in Singapore, it's about 31%. It goes as high as 92% in Bangladesh. In Myanmar, they did a literature search. It's about 48%. In places like Vietnam, it's up to 75%. Now, the main causes of eradication are non-compliance, followed by drug resistance, and perhaps a selection of PPI. I won't touch much about non-compliance, but suffice to say, on a 1 daily dose versus a BD dosing, for 1 single tablet, the compliance can drop by as much as 25%, and these are all published. Now, unfortunately, with the HP eradication regime, we started with dual therapy for 7 days, then 10 days, we then increased it to 14. Subsequently, we had triple therapy, and now we're on going to quadruple therapy. And all this is because of the drug resistance. Now again, the pattern of Helicobacter antibiotic resistance varies in ASEAN country. In Singapore, clarithromycin resistance is in the region of 17%. Metronidazole is 48%. As you can see, some countries would have higher clarithromycin resistance, such as Vietnam, 30%, and metronidazole, 70%. Now, in particular, these two resistant profile impacts the cure rate. We see very little resistance across the board in amoxicillin and in tetracycline. Now, this is important, which I will show you later on. Now, this is just a graph depicting the trend in Singapore over 1 decade from the year 2000. In year 2000 to 2002, our metronidazole resistance was in the region of 25%, going up to almost 50% by the time it was 2012, a decade later. Equally, the clarithromycin increased from 7.9% to 17.1%. The significant resistance rate for clarithromycin is anything above 15%. Now, this is a publication on the Vietnam experience. It's a bit of a busy slide. I just want to highlight the fact that in the early 2000s, triple therapy achieved eradication rate of over 90%. But in the latter years, as you can see, similar triple therapy, similar duration, we are only achieving rates of 60 odd to 70, 80%. Now, this is purely based on the fact that there are increasing clarithromycin resistance in Vietnam, also metronidazole resistance. So in the management of H. pylori, the Maastricht Florence consensus report, in areas where there's high clarithromycin resistance above 15%, certainly a bismuth quadruple or non-bismuth quadruple concomitant therapies are recommended. In places where there are high dual clarithromycin and metronidazole resistance, then bismuth quadruple therapy should be the first line. What about in Singapore? Well, in Singapore, there's a publication on some local experience in one of our general hospitals here. At least over the past 2 decades, despite the increasing rate of clarithromycin resistance, it seems that clarithromycin-based triple therapy continue to have success of eradication exceeding 90%. However, the duration of therapy has been lengthened from has been lengthened from 1 to 2 weeks to maintain efficacy. And the current use empiric second-line therapy in Singapore is either 2 weeks bismuth quadruple therapy or levofloxacin-based triple therapy comprising of PPI, levofloxacin, and amoxicillin. In my practice, however, I see quite a number of international. So what I have done is actually my standard HP eradication therapy is a non-bismuth-based quadruple therapy. And this followed by an ASEAN survey back in 2018 that in clarithromycin and metronidazole resistance remains a very major problem. Again, they stipulated that the prevalence of clarithromycin resistance above 15%, standard triple therapy could not be recommended as first line, and quadruple therapy might be a better choice. And as I alluded to and shown you the data, amoxicillin and tetracycline resistance have very low prevalence. And perhaps in this region, we should consider using these two drugs in the first line therapy. They also recommended after the failure of second line, they should have culture insensitivity. And that's what I follow nowadays. And recently I had a patient that failed second line, and she had to be rescoped for culture insensitivity. And the turnaround time is about 1 week. And similar, the Bangkok consensus report, again, more or less states the same. If the clarithromycin resistance less than 15%, standard triple therapy for 14 days might still be useful. Second line therapy, we should use antibiotics not used previously, or with antibiotics with low resistance, such as amoxicillin or tetracycline. So what about proton pump inhibitors? I think the main role of PPI clearly in the H. pylori treatment is to elevate the gastric acid, leading to an increased population of dividing H. pylori, leading to the bacteria becoming more susceptible to antibiotics. By increasing the pH, it also reduces the degradation of antibiotics that are susceptible to a low pH environment. Hence, maintaining a gastric microenvironment of a pH above 6 is the key factor in the eradication of H. pylori. We know this because in early studies of standard triple therapy versus dual antibiotics without a PPI, the eradication rates were 68% higher in PPI-containing regime. Now, the effect of PPI on acid secretion is dose dependent. The higher the dose, we may get a higher gastric pH, hence improve the cure rate. Certainly, the genetic polymorphism of CYP2C19 plays a role. This is implicated in the metabolism of PPI. I'll show you some data that it actually does impact in patients who are extensive metabolizers. So what are the influence of PPI on the minimal inhibitory concentration of antibiotics? As you can see, metronidazole and amoxicillin before PPI treatment is relatively high in terms of micrograms per ml. And then it varies between individual PPIs. As you can see, with pantoprazole is 1.4 and cefprozil is 2.38 microgram per ml and rabeprazole 1.18 and so forth. And it tends to have more impact in antibiotics containing metronidazole or regime containing metronidazole and amoxicillin, and less so in clarithromycin. And again, not all PPI are built the same. This is a chart showing acid inhibition on the first day of dosing, comparing 4 different PPI. As you can see, there's the placebo, there's the omeprazole 20, that's pantoprazole, lansoprazole, and rabeprazole. This is the gastric pH over 24 hours. This is the daytime and the nighttime. There are also differences in terms of their bioavailability of day one, and also in terms of their response over the different genotype of the CYP2C19. As you can see, full dose bioavailability is available for rabeprazole, lansoprazole, pantoprazole, and certainly there's consistent response across all phenotypes and genotypes of the CYP2C19. So the importance of this polymorphism is that it affects the bioavailability of PPI and that it metabolizes it. Hence, it can cause quite marked inter-individual variation in terms of the intra-gastric pH, control of gut symptoms, or healing of esophagitis, and in turn affect the HB eradication rate. And it's our very early studies back in the late 1990s on the use of omeprazole. These are the extensive metabolizers versus poor metabolizers. As you can see, the Helicobacter eradication rate is much lower in extensive metabolizers versus intermediate metabolizers versus poor metabolizers, which they can achieve higher PPI concentration. And this is a slide on the use of rabeprazole where there is no difference in comparison between extensive and poor metabolizers in terms of the HP eradication rate. Now, we also need to understand what's the makeup of our population. So in Chinese population, just slightly over a quarter are extensive metabolizers. And in Caucasians, almost 3/4 of patients are extensive metabolizers. So I think knowing the makeup of these patients, then you can choose the regime suited for your patients. So coming back to the management of H. pylori, the Maastricht-Florence consensus report, I more or less follow this regime. So in areas of high clarithromycin resistance, which I think Singapore is, because our data actually shows that it's 17%. Hence, my first line is actually a non-bismuth quadruple therapy, PPI, amoxicillin, clarithromycin, and metronidazole for 14 days. I will use bismuth not as a second line for some patients. Patients coming from China has very high clarithromycin and metronidazole resistance. Similar to the Vietnamese patient, this would be my first line treatment regimen. What about alternative regimes? If bismuth is not available, levofloxacin can be used, rifabutin, and high-dose dual therapy, PPI plus amoxicillin. I'll show you some data later on. If tetracycline is not available, in high dual resistant areas, bismuth-containing quadruple therapy combining furazolidone plus metronidazole or amoxicillin plus metronidazole can be considered. Newer agents such as vonoprazan, which is a potassium competitor inhibitor, have shown, at least in Japan, that even with dual therapy versus a vonoprazan triple therapy, there are no difference in terms of eradication rate. However, this eradication rate in this day and age is probably not acceptable, as we should be aiming for a cure rate of over 90%. But at least it's a new agent that we may consider for patients who have failed multiple different regimes. So this is a slide on high-dose dual therapy in first-line treatment compared to patients having standard triple therapy versus sequential therapy. And you can see the cure rate is as high as 95.3% compared to the two different regimens. In patients with second line, you're still achieving almost 90% versus a 50 to 78% eradication rate. So in summary, I think the preferred first-line regimen should be dependent on local antibiotic resistance rather than any single recommendation. So you need to know what your resistance rate are to the two most important antibiotic, which is clarithromycin and metronidazole. And H. pylori regimen should have a cure rate of at least 90%. In places where clarithromycin resistance is less than 15%, then clarithromycin triple therapy for 14 days can still be recommended. All treatments are for 14 days in areas where clarithromycin resistance is more than 15%. First line would be concomitant PPI, amoxicillin, clarithromycin, and nitroimidazole, or bismuth-based quadruple therapy. If bismuth is not available, then levofloxacin, rifabutin, and high-dose dual PPI and amoxicillin may be used. Thank you very much.
Thank you very much, Dr. Vincent, for your very informative and interesting discussion about H. pylori. We will do Q&A question after 10 speaker. It's a time for 10 speaker. Professor Tatan is, she's a professor and head of the Department of Gastroenterology, University of Washington. Currently working as the Vice President of MRG and Liver Society. He will discuss about current management of GI. So Professor Tatan is, please.
Hi everybody, good afternoon. You hear me? So my topic is gastroesophageal reflux disease and management of refractory heartburn. I have no conflict of interest. So as you all know, GERD, gastroesophageal reflux disease, is one of the most commonly encountered GI disease in the clinical practice. Significant compromise in quality of life, potential complications like stricture, dysphagia, Barrett's, and leading to esophageal adenocarcinoma. So regarding American College of Gastroenterology guideline, GERD is defined as symptoms or complications resulting from the reflux of gastric contents into the esophagus or beyond. So it is into the oral cavity or even into the lungs. So regarding symptoms, the most common cardinal symptoms is heartburn and regurgitation. And other symptoms also included in GERD: water brush, dysphagia, chest pain, is non-cardiac chest pain, and other extraesophageal symptoms like cough, asthma, wheezing, and sleep disturbance as well. So this is the Montreal classification, classifying groups: it's esophageal syndromes and extraesophageal syndromes. Esophageal syndromes based on symptoms and endoscopic features like erosion or non-erosion, and the extraesophageal syndromes include other cough, asthma, or dental erosions, and other proposed associations like pharyngitis, sinusitis, and recurrent otitis media as well. So this is Los Angeles classifications of esophagitis, grade A, B, and C, and D. D is the most confluent erosions extending and to the whole circumference of esophagus. And there are risk factors for GERD, and surprisingly, hereditary condition, relationship with family members contain more than 30% of cases. Overweight, obesity, central obesity, pregnancy, alcohol, and fatty diets, they all are risk factors for GERD. And pathophysiology of GERD is multifactorial: motor abnormalities, anatomical factors like hiatus hernia, obesity. In that impaired lower esophageal sphincter, alias rest syndrome, and the transient lower esophageal sphincter pressure relaxation is main pathological mechanism. Usually, transient TLESR is normal phenomenon for the healthy person, but in GERD, TLER is too prolonged, maybe too prolonged or maybe too frequent, which can cause stomach contact into the esophagus. Extraesophageal manifestations are conceptual proposed pathophysiologies are direct acid damage to the pharyngeal mucosa or bronchial microaspiration episodes can cause extra wheezing or other extraesophageal manifestation. So diagnosis is mainly based on the clinical symptoms, and empiric trial of acid suppression is often used as a diagnostic test. In the meta-analysis of 6 RCT suggests the high dosage of PPI, this is twice a day dose of PPI for 4 weeks, has acceptable sensitivity and specificity for diagnosis of GERD. So this is PPI trial is considered as an initial useful test for a primary care physician. We will do only further diagnostic tests is only in case of refractory to therapy, complication, if you want to assess complications or to establish the alternative diagnosis rather than GERD. So these are the current available therapeutic modalities for GERD. Our lifestyle mainly is lifestyle modifications to raise head end of the bed from 30 to 45 degrees, avoid meals within 3 hours before bedtime, and weight loss. These strategies are definitely respond to GERD, one of the main therapy for GERD. And the other medical therapy like antacid, alginate, and proton pump inhibitors, H2 receptor antagonists, prokinetics, baclofen, and these are the medical management. And if it does not respond, or if there's indication for surgical therapy like fundoplications and endoscopic therapy, endoluminal therapies like strata, radiofrequency ablation of the GE junction. So these are the currently available therapeutic modalities. And the refractory GERD, I will also focus on the refractory case of GERD because approximately 1/3 of patients continue to experience symptoms of GERD on once daily PPI, and 10% patient continue persistent symptoms on twice daily PPI therapy. So while on long-term PPI therapy, approximately 50 to 60% of patients complain persistence or breakthrough symptoms. So what is the definition of refractory GERD? It is defined as persistence of typical symptoms that do not respond to stable twice daily PPI dosing during at least 12 weeks of treatments. So this is up to 30% of the GERD patient experience refractory symptoms. So refractory symptoms can cause poor quality of health-related quality of life, and the low work productivity, greater absenteeism from work, and psychological impairment, and significant health risks associated with long-term PPI is the additional complications of refractory GERD. There are many causes of PPI refractory GERD or heartburn. So they are related acid reflux related or other non-reflux related. So once patient is suspected of refractory GERD, you need to think about drug compliance or improper dosing of PPI, residual acid reflux, non-acidic weakly acid reflux, and the acid pockets, etc. And in addition to that, PPI metabolism, CYP2C90 polymorphism, and that Dr. Lai already explained this. And the other non-reflux related are functional chest pain, heartburn, and esophageal motility disorder, and eosinophilic esophagitis, though it is rare in the clinical setting. And then regarding drug compliance, if it is reflux related, you need to explore the drug compliance. Poor drug compliance and improper dosing. In case 38% of the patients only patient in GERD, only 38% of the patient strictly adherent to PPI, and 30% of the patients over 1 year, they only adhere only 30% of the patient PPI adherent. And the administration of the dosing and administration of the PPI also important. Administration of PPI should be 30 to 45 minutes before a meal is crucial because gastric proton pumps are activated following food intake. And another theory is acid pocket. The acid pocket is an area of unbuffered acid compartment in the proximal part of the stomach, particularly in the fundus of the stomach, and it serves as a potential reservoir for acid reflux in healthy as well as GERD patients. So patients with GERD are predisposed to upward migration of proximal margin of the acid pocket. So the other mechanisms include weak acidic or non-acidic reflux. In that case, patient has no normal pH range, but it's lower limit of the normal, but patient is hypersensitive to the acid reflux, and the PPI metabolism, CYP2C90 polymorphism. This genetic polymorphism, in case of rapid metabolizer, PPI efficacy is reduced. And nocturnal acid breakthrough, this is another theory. Persistence of intragastric pH less than 4 for more than 1 hour during the nighttime. That's why the H2 receptor antagonist or adding of the H2 receptor agonist at nighttime is another therapeutic modality, but clinical significance is unclear in some studies. Eosinophilic esophagitis is you also think about eosinophilic esophagitis in case of refractory GERD, because the symptoms of eosinophilic esophagitis is similar to the non-cardiac chest pain, like heartburn, chest pain, and dysphagia. And but actual prevalence of eosinophilic esophagitis is low. Another differential diagnosis, this is reflux unrelated cause, functional heartburn because 60% of the patients classified as GERD, GERD has a functional heartburn, so that we have wrong diagnosis with GERD therapy, and they have less response to PPI therapy. So functional heartburn is defined in Rome 4 functional GI disorder criteria: burning, retrosternal discomfort or pain that is refractory to optimal anti-secretory therapy. This is PPI in the absence of objective evidence of GERD or major esophageal motility disorder. So that these patients group has no GERD, no motility disorder. They only have a functional burning, retrosternal discomfort and pain only. So may have other they also have other coexistent functional disorders like functional dyspepsia and irritable bowel syndrome. And another cause is esophageal hypersensitivity. This is the presence of typical reflux symptoms, but in pH study, there is no acid reflux as well as in the no pathological reflux on endoscopy, but they have positive symptom reflux association. It means that patient doesn't have reflux, but patient experience the symptoms of reflux. So there's a positive symptom reflux association. It's different from the functional esophageal disorder. And esophageal hypersensitivity experience about approximately 30 to 35% of patients with non-erosive reflux disease. So regarding functional GI disorder, this is Rome Foundation class of guideline started from 2000. In Rome 2 Foundation line show that heartburn and if patient is heartburn and normal endoscopy, we diagnose as one is divided into non-erosive reflux disease or functional heartburn, which includes reflux hypersensitivity and non-reflux related heartburn. But in Rome 3, it moved to the Rome 3 in 2006, definitions a bit changed. Reflux hypersensitivity, abnormal acid exposure, and non-reflux related heartburn responsive to PPI. These groups included in the NERD, and another entity is functional heartburn. But the latest 2016 Rome 4 guidelines show that in patients with heartburn, normal endoscopy and normal pH, we divide it into functional heartburn and the reflux hypersensitivity. But if patient has a positive symptoms reflux association, we classify as reflux hypersensitivity. In case of patient without negative symptoms, reflux association, normal acid exposure, in these group are labeled as functional heartburn. And if the patient has positive or negative symptom reflux association, but in case of abnormal acid exposure, we include non-erosive reflux esophagitis. So diagnosis of refractory gut again depend on the thorough clinical evaluation, and later on upper GI endoscopy, esophageal motility, manometry or reflux monitoring of this pH study. Clinical patient's history and physical examination is the most important for evaluation for refractory gut. We have to explore the patient's symptoms of typical or asymptomatic, the typical symptoms of GERD or time of occurrence of troublesome symptoms. There is nocturnal or post-meal or compliance, proper dosing and timing of PPI, presence of other functional GI disorders such as functional dyspepsia, insomnia, and alarming symptoms like weight loss, anorexia, or upper GI bleeding. And also need to explore coexistence psychological comorbidity. So if the patient with reflux symptoms, we have to, if the patient's PPI, first step is to optimize PPI therapy. So improve compliance, ensure proper dosing time, split the PPI doses, or switch to another PPI, because there is a reason that we have a genetic polymorphism of CYP2C19 cases, rapid metabolizer. So we have to change the another PPI, which does not metabolize by CYP2C19. It is rabeprazole, for example. And lifestyle along with PPI dosing and the timing, lifestyle modifications also important. Avoid large spicy fatty meals, lose weight, head elevation, and avoid eating 3 hours before bedtime. So another studies, reflux monitoring. Patients who are refractory to PPI therapy, normal endoscopy should undergo reflux monitoring. It is whether the patient has acid reflux or not. So that reflux monitor acid exposure time, number of reflux episodes, and symptoms index and symptoms association probability. So in case of reflux monitoring, we can do PPI on therapy or PPI off therapy. In PPI off therapy, reflux monitoring is indicated in case of GERD, which is unproven and no prior positive page testing. And in case of patient who undergo surgery or endoscopic reflux therapy preoperatively. And on PPI therapy, reflux monitoring is performed in patient with proven GERD in form of severe esophagitis and long segment pruritus and prior abnormal pH tests to establish relation between reflux episodes and symptoms. So another modality is high resolution esophageal manometry. Although it is not the first line test, HRM has a role in defining GERD alternative diagnosis, achalasia, rumination syndrome, and supragastric belching. And it's also useful for esophageal peristalsis function before definitive surgery, anti-reflux surgery to predict post-operative complication like dysphagia. And HRM is also performed to localize the lower esophageal sphincter before placement of pH probe. So combine multi-channel intraluminal impedance pH monitoring is used in off or on therapy, and this is considered as a gold standard in the evaluation of PPI refractory GERD. So these are the medical management. We have to start with medical management in case of refractory GERD. For patient with abnormal endoscopy, pH testing or impedance testing, it is coexistent with reflux as the etiology of symptoms. So patients still have reflux GERD, confirmed GERD by endoscopy pH test, pH impedance test. We have to use PPI. It is the mainstay of therapy, and we have to make sure proper timing, compliance, and avoid CYP2C19 polymorph metabolizer. And long-acting, and we can also use long-acting PPI with alternative metabolic pathway like elaprazole or tanotobrazole, which is not available in our country, and also potassium competitive acid blocker, PCAP, rivaroxaban or soraproxen, etc. Alginate acids work by forming a mechanical barrier between gastric contents and the lower esophageal sphincter. This is useful in case suspected of acid pocket. The multi-center placebo-controlled randomized trial show that alginate is effective symptoms improvement when it's combined to PPI. It's compared to placebo. Prokinetic drugs, it increase lower esophageal sphincter pressure, enhance esophageal clearance of reflux material, stimulate gastric emptying time, so that it is theoretically it is useful drugs for our refractory gut. But in meta-analysis, the addition of prokinetics to PPI has no significant effect on symptoms or endoscopic response to gut, but its quality of life is better in meta-analysis. And other reflux inhibitors like baclofen, it inhibits transient LES relaxation. It is GABA agonist and decrease acidic and non-acidic reflux episodes. You can use as a monotherapy or add-on therapy to PPI. In the meta-analysis, baclofen reduced the number of reflux episodes, average length of and occurrence of TLE, transient lower esophageal sphincter relaxation. But this is because of the neurological side effects. Most of the patient not tolerate to these drugs. And neuromodulator, it is very useful for the esophageal hypersensitivity and functional heartburn. This is alternative diagnosis for GERD. In randomized trial, citalopram is compared to citalopram and placebo group. Citalopram is only 38% of the patient with citalopram group reported reflux symptoms. And also fluoxetine reduces the percentage of heartburn-free days. Now, what is the role of endoscopy in refractory GERD? Usually, ASGE guidelines recommend that usually endoscopy is not indicated in the patient with GERD. But in case of refractory GERD, we can diagnose erosive esophagitis or Barrett's esophagus and rule out eosinophilic esophagitis and suspect severe esophageal motility disorders or pill-induced esophagitis or esophageal lesions associated with skin disease like lichen planus. So this is an endoscopic management of GERD. If the patients fail response to medical therapy, we can try with endoluminal management of GERD. These are the radiofrequency ablation called Stratel procedure, endoscopic fundoplication, multiband anti-reflux mucoectomy. And the endoscopic fundoplications, the basic, all the endoscopic managements of basic principles are endoscopic plication and reinforcement of esophageal junction. But in systemic review and meta-analysis, and these endoscopic procedures are safe and effective in patients with refractory GERD, and adverse effect is overall adverse effect rate, event rate was only 2%, and PPI can discontinue in even 89% of the patients after therapy. But we don't know the long-term outcome. The surgical management, laparoscopic fundoplication or anti-reflux surgery, Nissen fundoplication is effective in patients with typical GERD symptoms with acidic or non-acidic reflux. And the long-term LAS provides greater reduction in esophageal acid exposure after 5 years compared to PPI therapy. So this is the management algorithm for GERD. If patients' GERD symptoms are like heartburn and acid reflux, we will start with PPI therapy with empiric single-dose PPI therapy or lifestyle modification. If the symptoms resolve, taper PPI therapy to lowest effective dose. If symptoms persistent, we have to ensure compliance, proper dosing of the PPI or twice daily PPI. Can improve twice daily PPI use for another 8 weeks. And if the patient is alarm symptoms, we have to do endoscopy or other further investigation. If patient refractory to GERD symptoms, we have to evaluate again PPI regime and compliance. If it is adequate, we have to undergo pH monitoring. If patient has persistent acid reflux, so this is NERD or we will proceed to newer long-acting PPI, alginate add-on, or anti-reflux therapy or endoscopic therapy. This is confirmed acid reflux disease. If patient is non-acidic reflux, we have to add prokinetics, baclofens, or anti-reflux therapy, endotherapy. Still useful. And patient is esophageal hypersensitive, no reflux, no acid. So we have to think about alternative diagnosis like functional esophageal disorder. So that this must be treated with neuromodulator like tricyclic antidepressants or SSRI. I'm sorry. So in conclusion, GERD is common disorder. Definitive diagnosis and alternative diagnosis mandatory for refractory GERD. Various medical therapy endoscopic and surgery are available, but indications, long-term outcome and safety need to be considered before prescribing this therapy. Thank you very much for your kind attention.
Thank you, Professor, for your interesting and important discussion about GRD. Now it's the time for question and answer. I received a few questions from audience. The first question for Dr. Vincent Lai. So could you please share the role of therapeutic H. pylori vaccine current status?
Okay, so not a lot. I mean, the main study was mainly in pediatrics, I believe, but it's something that I think, you know, what the COVID is bringing. Vaccine is always a welcome approach to it. But as far as I know, there are no real approved HP vaccine at this present moment.
Oh, thank you. Now, another question for Dr. Tantan E from Orient. The question is, what are the long-term side effects of PPI?
Yes, this is a good question. So PPI therapies, because PPI inhibits almost permanent acid inhibition, so that the complication arising from acid inhibition. The most common side effect is infection, particularly in prostate. So infection, chronic diarrhea, and also it inhibits vitamin D absorption, causing osteoporosis, and also along with Clostridium deficit infection, pneumonia, and also this is osteoporosis and other. You hear me?
No. Professor Tana A, please loud. We can hear your voice.
Can you hear me?
Yeah.
You hear me? Yeah.
Yeah, we can hear you.
Yes.
Okay.
Long-term PPI has many side effects because of it inhibit acid almost permanently. So this is the complication arising from acid inhibition. The most commonest complication is infection, particularly Clostridium difficile infection, as well as pneumonia, and also even cause bone fracture because of the vitamin D and calcium absorption, and which depend on the acid media, so that the patient can cause osteoporosis and bone fracture as well.
Another question to Professor Vincent Lee. Is superior PPI and HPV therapy?
Sorry, is what not present higher eradication rate? Is that the question?
Yes.
Okay, so most of the studies are in Japanese cohort, so it hasn't been validated for other countries. But if we work on a basic principle that the eradication rate is higher, the higher the pH, then it seems that there may be a trend for that. So the data that I've shown you earlier, that the dual therapy was equivalent to the triple therapy on vonoprazan. I think it's something that is interesting, but has to be validated further.
Another question for Dr. Tantan E. Is there any link between GERD and H. pylori?
Yes, actually, H. pylori is not the cause for GERD, but if the patient persistent have a refractory GERD, you have to think about H. pylori related dyspepsia as an alternative diagnosis. And then some study, but it's not significant. Long time ago, H. pylori eradication therapy can was GERD, and there are some studies previously.
Thank you. Another question of Dr. Visinda. Why amoxicillin is not included in bismuth containing quadruple regime?
Actually, it is. So the at least the regime that I'm using is actually for the bismuth. You can't use amoxicillin or with tetracyclines, right? So long, because amoxicillin and tetracycline has inherently very low resistance rate, you can use it with a like a metronidazole or tinidazole. Because of the dosing frequency, I actually use tinidazole because it's a BD versus metronidazole, which is a TDS regime.
Thank you. Another question for Professor Tai. Is there any illuminated trend for GERD in Myanmar?
I'm sorry, we cannot do endoluminal therapy for GERD until now.
Thank you. Another question for Dr. Lee. Is there any adjuvant therapy for H. pylori eradication? And then another question is the role of 5-UTP-based eradication therapy in Asia, especially in the trade of tuberculosis resistance.
So sorry, I missed that. What's the first question?
First question is adjuvant therapy to improve HP eradication regime.
Again, I can't hear very clearly. Let me see if I can read the question. It's what?
Yeah. Second last one.
Any adjuvant therapy? Oh, sorry. Yeah. Okay, any adjuvant. So the adjuvant therapy, not really. I mean, there's some publications in terms of limiting the side effects by addition of probiotics. So there's something on probiotics with Helicobacter, which may improve eradication in the sense that it will reduce antibiotic-related diarrhea. But my take on this is that they're already on quadruple therapy. If I add another probiotic, then you will be taking 5 different drugs. I think it defeats the purpose. But so far, my patient seems to be able to tolerate the quadruple therapy. Very few fail second line. I'm doing very few culture and sensitivity.
Another question for you is the role of rifabutin-based eradication therapy in Asia.
Okay, so rifabutin, again, I alluded to it on my slides. It depends on whether there's the standard therapy that you have, whether you have bismuth or not. If you don't, then I think it's something that you can use. Personally, I have never used it because we have availability of bismuth.
Thank you. Another question for Professor A. Is there any role of sucralfate in management of GERD?
So sucralfate, I'm not sure it is alginate, but there is some role for in patient with suspected of acid pocket. So antacid is some role, but it's not a definitely response to definitive treatment for GERD. But there's some symptoms response, not sucralfate, it's antacid. But antacid plus alginate plus PPI have some role for acid pocket, acid secretion from the acid pocket. So, but the sucralfate alone is not a response good for GERD.
Thank you. Another question for Professor Lee. What about the role of N-acetylcysteine in H. pylori eradication?
N-acetylcysteine. Honestly, no, I have no experience on using N-acetylcysteine. Being a liver physician, I use that for my Panadol overdoses and acute hepatitis.
For me, we use N-acetylcysteine to see clearly gastric mucosa, not for H. pylori eradication.
Oh, it says H. pylori eradication here. Oh,
Yep.
No, I've not.
Is there any question from audience? If no, I would like to conclude today's session. Thank you very much for Myanmar Medical Society Association to arrange for management of common Abajian problem. And very thanks for two speakers, Dr. Brisbane Wright from Singapore and Dr. Tatani from Tenganjung General Hospital. Also, thanks to participants who actively participate in today's topic. And finally, not the least, the sponsor designed for such kind of scientific meeting. I hope we can do more such kind of CME program in future. Thank you, everyone. Thank you, Dr.
Thank you.
And Society, and everybody. Thank you.
Thank you. Stay safe.
Thank you.
Thank you very much. The chair of symposium, Professor Tamian, speaker Dr. Brisbane Lee, and Professor Tanda A, all the participants who made active listening and asking questions. The last, not the least, is the academic support of the Eastern Company. May I announce that today's Zoom symposium on current management of Abajian programs is successfully concluded. Thank you very much.
Thank you.
Thank you.